Good afternoon, everyone. Thank you for joining us for Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. So moving on, it's a great pleasure to have our speaker today, known to many of you, Dr. Christina Wolfson, who is a professor in the Department of Medicine, Epidemiology, Biostatistics, and Occupational Health at McGill University. Dr. Wolfson is also the associate member in the Department of Mathematics and Statistics, Department of Neurology and Neurosurgery, and senior scientist in the Brain Repair and Integrative Neuroscience program at the Research Institute of the MUHC. She's trained as a statistician and an epidemiologist. Her program of research concerns population neuroscience, within which she examines the epidemiology of neurodegenerative disorders, including multiple sclerosis, amyotrophic lateral sclerosis, epilepsy, and Parkinson's disease. She is a principal investigator on the Canadian Longitudinal Study on Aging, leading the Neurological Conditions Initiative and the Veterans Health Initiative. She's also the director of the NMS National Education and Training Program and currently serves as the McGill University Research Integrity Office. It's a great pleasure to have with us Dr. Wolfson today. Thank you so much for being here.
Thank you, and thanks for the invitation. As I already said to Nadia, it would be great if we could see each other in person and I could gauge your interest and enthusiasm by seeing your faces, but it is what it is, and I know I'm the same. It's easier to do virtual. We get a much better attendance. So anyway, I'm happy to be here. So I want to just start by saying, why would I talk about something called the value proposition for a study? And this actually arose just a few weeks ago. So our study, and I'm going to talk about the study itself. But we're just over halfway through our timeline. We're due to complete data collection in 2033. And we're starting to think about what's going to happen after. Certainly as we became engaged in the development of this study in 2001, we never thought about what was going to happen at the end. We were just concerned about how we were going to get this thing up and running. Now we've got to think about a legacy platform. And we have an advisory council for the longitudinal study on aging. And there are people on that advisory council who are not in academia, who are in business and in the pharmaceutical company, et cetera. And they provide advice to us. And in our last meeting a couple of weeks ago, the issue is, well, what's the value proposition for the Canadian Longitudinal Study on Aging? And, I had to Google and find out what that means. And it basically means, what can this study and this platform offer to others? So that's how I decided to kind of phrase my presentation today. So that's why it's called the value proposition. So I have to say that I'm giving this presentation on behalf of a very large team of researchers across Canada as well. Okay, so my objectives are, I'm hoping you're going to become familiar, if you're not already, with some of the components of the study design methodology and the content of the study, and we won't have a test at the end. And one of the main things I want to do, for those of you who have not used the data from the CLSA, is to give you a little bit of a clue as to what the potential for research for yourselves could be in this platform, and a little bit on how to access the data. So my disclosures, basically peer-reviewed funding and no other disclosures. So the scientific leadership of the CLSA, we're 3 PIs. The lead PI is at McMaster University. There's myself and another PI at Dalhousie, and we're joined by 2 co-PIs and an associate scientific director. And I think, in contrast to many large studies over time, we 3 PIs have been together from the get-go. We are the ones who developed the study, launched the study, and obtained the funding for the study. And in fact, before we got together to discuss this, we had never worked together before. And the fact, I think, that we're still working together says something, I think, about the importance of this study. So what is the value proposition? So there are two things within the CLSA to think about. One is that it is a platform. So there is infrastructure to facilitate interdisciplinary population-based research, and I'll talk a little bit about the infrastructure, but it is also a research study. So this is not a sort of random collection of information from a large number of participants. Every step of the way, we have a carefully designed protocol and research questions that we anticipate researchers would like to ask, and then we, along with our working groups, come up with measures, state-of-the-art measures, if we can, to gather that kind of information. So together, the research study, the participants, the data, the biological samples form the research platform in addition to the physical infrastructure that we have. So for those of you who are not aware, it's a big study, not as big, obviously, as the UK Biobank, but I think around the world, it's one of the larger studies. There are about 160 researchers involved in the planning and data collection. We have 26 institutions across the country. It's multidisciplinary, and we're following 50,000 plus Canadian residents who were aged 45 to 85 when we recruited them for 20 years. And we're funded for the operation, so the data collection, primarily by the CIHR as a directed research grant. So we do have to apply for renewals every 6 years, and it's a major undertaking. And we're also funded for the infrastructure by the Canada Foundation for Innovation. And at the very beginning of the study, we were fortunate to get a CFI award, and we've just received another one about 2 years ago because our equipment was now over a decade old, so we're renewing most of the equipment. We have a number of other partners, and you'll see as we move along what some of those are that are providing funding or in-kind support in different ways. So it's a national study. This map, just the little green dots refer to the data collection sites, so the physical locations where participants will come in. Some people may ask, why there? Why in those places? Well, on the one hand, we had to find sites where there was a critical mass of researchers that would be able to take on this undertaking. So there are, in fact, 3 provinces in which we do not have a physical data collection site, because when we started in 2000, we started data collection in 2010, we weren't able to engage researchers. Things are very different now, and the future may be different, but this is what it is now. The blue dots basically refer to the individuals that we follow only by telephone. So we do telephone interviews in all 10 provinces, and we do in-home and in-person data collection in 7. So I talked about the infrastructure funded by CFI. So we have 11 data collection sites in 7 provinces, and they are bespoke for the CLSA. They are designed specifically for the CLSA, and all of the equipment is identical. So when we order a DEXA machine, we order 11 and ship them out across the country. We have 4 computer-assisted telephone interview sites that we created or modified slightly using CFI funding. One of them at the University of Sherbrooke does French and English language interviews. The National Coordinating Center is at McMaster University. The Data Curation Center that manages all of the data and assesses the data and looks for skip patterns, et cetera, and prepares data sets for users is at the Research Institute on Guy Street. We have a very large biorepository and bioanalysis center that we built at McMaster University to store our biological samples, and we have an epigenetics center at UBC. I can't resist to show people this. This is, when there are ever photographs in the press about the CLSA, they always go to the biobank because it's really flashy. So just to say that we have a biobank where we store, as I said, the biological samples. Because it is CFI infrastructure, it is available for use by other researchers, and there are some other research teams who are storing different samples there. So I just want to give a plug to the infrastructure nature of the CLSA. So these are our collaborating institutions. You don't need to read those in great detail. So let me get down to some of the design issues. Okay, so when you design a study of this magnitude and of this scope, the question is, how do you find people? So this, remember, we were doing this between 2001 and 2008, and we entered into a partnership with Statistics Canada. We actually connected with the CCHS 4.2 on healthy aging, which took place in 2008 and 2009. And we were able to include in the CCHS a question asking participants if they agreed to share their contact information with the CLSA. This is the first time that Statistics Canada had done that for a research team. And that was, I'm going to say a struggle, but a struggle that was well worth it. So we were able to connect ourselves to the CCHS. We helped them develop the content for that study as well. And in return, they allowed us to ask this question. And we did get about 8,000 participants through that venue, but that wasn't enough. So we entered into partnerships with provincial ministries of health where that was allowed. And we used health card registration databases, including mail-outs and return of consent to contact forms. So those of you who are thinking about statistical issues here, you'll see we've got 2 sampling frames already. We then filled out the rest of our sampling, because we had a lot of people we had to contact, with random digit dialing. And we engaged Léger Marketing in the beginning, and then it became a little too expensive. So then we developed a strategy for our own computer-assisted telephone interview sites to do random digit dialing. What this meant is having the 3 sampling frames, and it meant a few things, and you'll see on the next slide one of the implications. But certainly one very important implication was, how do you develop sampling weights? So we were very fortunate to be able to work, and we continue to work, with probably the preeminent sampling statistician in Canada, Dr. Mary Thompson, who is at Waterloo, who has been working with us for over a decade in developing sampling weights, taking into account the different sampling frames and also non-response. So the CLSA had exclusions at baseline, and these exclusions are important. So we excluded residents of the Northwest Territories, Nunavut, and Yukon. And I should say that our exclusion criteria were driven by the exclusion criteria used by Statistics Canada, because that was our first sampling frame. We excluded individuals living in institutions. We excluded individuals living on First Nations reserves, full-time members of armed forces, temporary visa holders, and we also excluded individuals who were cognitively impaired and unable to communicate in French or in English. And you can imagine, I mean, you can think very clearly doing a study of aging, excluding people living in institutions and with cognitive impairment means at baseline, you've got a healthy group of individuals. That was a decision that we took in order for us to be able to move forward. It obviously does have implications now for inference that people are making in their research. Excluding individuals living on a First Nation reserves means that the number of Indigenous participants that we have is relatively small, because they would have only been recruited if they were living off First Nations reserve. And this, of course, is a limitation, and we're working very closely with Indigenous researchers to, first of all, to govern the data from those individuals, but also to perhaps develop an Indigenous cohort, which is very similar to the CLSA, except for the sampling strategies. So I'm going to just give you a little bit of terminology to remember. So there are 2 cohorts in the CLSA. One we've called the tracking cohort. These are individuals who are followed by telephone interviews and web-based interviews. That's not enough in a study of aging, of course. So we have a little over 30,000 participants who live within 25 to 50 kilometers of one of our data collection sites. And their data are collected through in-home interviews, web questionnaires, and physical assessments at the data collection site. And we've also most recently introduced wearables. So here's a little bit of a timeline for the CLSA, if you like. So overall, there are 51,338 participants who were recruited between the ages of 45 and 85. We followed them over time. It took us 5 years to recruit and complete the baseline assessment. And from that point on, we're on a 3-year cycle where we do follow-ups. For the most part, we repeat everything that we have done previously to maintain the temporality of what we're doing and to be consistent from time point to time point, but we're also adding and removing certain things at each wave, and I'll talk about a few things that we've added shortly. So in 2020, which was sort of in the middle of our second follow-up or our third wave of data collection, COVID hit, and we couldn't, of course, do our in-person assessments, so we pivoted completely to telephone interviews and web-based interviews at that time. But we're fortunate to be able to add 2 COVID studies with our CLSA participants, and I'll touch on those a little bit later. So here we are in 2024. We're just about to finish follow-up 3, which is our 4th wave of data collection, and we will start immediately after with follow-up 4. And we're scheduled, or our funding line is to go to 2033. And as I said, we're now discussing what happens in 2023. And of course, we realize we have to plan that now. Is there any way to keep this cohort going? Should we add new participants to this cohort because it is a closed cohort? Should we have some other strategies? Who manages the data when CRHR funding finishes? Who manages the infrastructure? So lots of questions that we're addressing at this point in time. So don't expect anybody to read this, but just to give you an idea of the breadth of the CLSA data collection, our participants go through 1 to 2 hours of interviews, either, as I said, telephone, web-based, or both. We ask a lot of health information, of course, self-reported, a lot of lifestyle and socio-demographic information, and a lot of psychosocial information. And it's a long questionnaire for the folks on the phone, and even for the web, and even for in-person. But the challenge is everything seems to be important, and what do we exclude? Just thinking about the depth of what we collect at our data collection site. So the physical assessments, we do the standard stuff. We do height and weight. We have a DEX, as I said, so we have bone density, body composition, we do blood pressure, we do ECG, we have carotid ultrasound, we do spirometry, tonometry, other vision testing and hearing testing. We do performance testing on all participants, even those who started at age 45. We were having them do the chair rise and grip strength and the 4-meter walk. And we have the wearables. We do cognitive assessments, looking at memory, executive function, and reaction time. And those folks who come in, we take a blood sample and a urine sample if they agree. And we've just introduced on 6,000 participants a stool sample. And we have recently started a study where we're doing MRI on about 2,300 of our participants. And I think even though these circles are sort of separate, the fact is that those folks who have the MRI have, of course, the biospecimen collection, the cognitive assessments, the physical assessments, and all the questionnaires. So when we get into the smaller samples, those individuals have incredible depth of data collection. So we collect the blood. We do a little bit of blood analysis on site, but primarily the blood samples are frozen and shipped weekly to our biobank at McMaster University. Those are then analyzed. They're either analyzed by the lab at McMaster, or we work with other groups in order to give us analyses on as many participants as we can. And for some of the more complex, it's a little bit more expensive. So we don't have that on all participants. We've completed it for baseline and are now doing these analyses as appropriate for follow-up 1, but that requires additional funding, as you can imagine. So talking a little bit about the mobility trackers, which we've just introduced, and for those of you who use mobility trackers, doing it at this magnitude, it is a little tricky. We had a recall of the chargers for some of the trackers just a couple of weeks ago. So we had to get into contact with all of our participants and tell them to stop using the charger and mail them the new charger. So a lot of the logistics are challenging. So the participants are being asked to use a tick watch and actigraph, and that is done on all of our comprehensive participants. So right now we're probably at about 27,000 of those. On a smaller subset, the 2,360, we're doing assessing sleep quality and sleep patterns, and we're using the MUHC headband. And this has been a new, I don't want to call it a challenge, but it's been a new experience for our staff, learning how to use these things, learning how to train our participants to use them, getting them to the participants and reminding the participants to bring them back. So there have been a lot of logistics involved here. But again, these data can connect with all the other data that we've collected. So we're adding some new measures which we have not had before. So we're including now in our next wave vision contrast sensitivity to add to the visual testing. We're adding as an assessment of olfactory function. That's something that I've been pushing for a number of years, working in neurological diseases. And so we're going to be using something called the snip and sticks at our data collection sites, starting in our next follow-up, which will begin in the fall. We're going to do echocardiography, and we've added a temperature measurement because that was a question that a few people had asked us, actually geriatric researchers saying, why don't you take participants' temperature? We did during COVID, of course, if they came in to give a blood sample. So now we've added that as a measurement. We're going to do repeat metabolomics, epigenetics, and biochemistry. And we've added urine biomarkers. We've added some questionnaires, sleep chronotype, nutrition chronotype, a little bit more in healthcare utilization. And as a response to a large number of participants asking us, we've added questions on sexual health. We've also added a small set of questions on cannabis use and a WHO ageism questionnaire, which I believe has 5 questions in it. So we're always adding things. You can only imagine the discussions that we had. If we add all these things, what do we take away? So we have taken a few things away, and oftentimes we'll decide to take something away because we see that the measurement has not changed over time, or we see that researchers aren't using it. So we have taken some things away in order to give space for new measures, and we have to be able to do that at each wave of data collection. So what are enhancements that we've done to the platform? As I mentioned, when COVID hit, we rapidly, within a month, were able to pivot to a questionnaire-based study on COVID, and we were able to recruit 28,000 of our participants to do that. This also allowed us to keep our staff. They were working from home doing these interviews. With funding from the COVID Immunity Task Force, we were able to complete a COVID-19 antibody study on about 18,000 participants. A few participants were able to come in to the sites because some of the sites had started to open, but the vast majority were mailed a dried blood spot kit in order to do that. We added a memory study of about 600 participants where they were assessed by a neurologist or a geriatrician or a clinical neuropsychologist for dementia or for major and minor neurocognitive disorder. And then we're now comparing that to the data that we have to see whether our cognitive testing could actually predict who's most likely to actually have a minor or a major neurocognitive disorder. The Healthy Brains, Healthy Aging Initiative is funded by the Weston Family Foundation, and that's the study where we are doing MRIs and sleep studies and stool specimens on about, the MRIs on about 2,300, but the whole cohort itself is about 6,000. So there are a lot of things going on. We didn't start these enhancements till COVID hit because we felt we couldn't cope with anything more than just the core data collection. But now I think we feel it's really important as our cohort ages to, of course, move into brain aging. So that's what the CLSA is doing. So let's talk about losses. So by the end of our second follow-up, about 7%, just a little over 7% of our participants had withdrawn from active data collection. Everyone, of course, has the right to withdraw. Fortunately, most of them had consented to continue data collection through data linkage with health administration databases. And I should say, I didn't mention that in the beginning, 96% of our participants at baseline agreed they provided their health insurance number. So at some point in the future, we hope to be able to link with the health administration databases. And I'm very excited to in a further slide to be able to tell you that that's been successful to some extent. About 7% of participants had died since their baseline assessment. So we really have very good retention in terms of losses to follow-up and withdrawals in the CLSA. That's a little bit of a double-edged sword, because when we did our calculations, I think we overestimated the losses and the withdrawals. So now we have more participants than we thought, and that is a bit challenging for our fixed budget from CIHR. But I guess it's a good problem to have. So how do we try and prevent losses and to prevent withdrawals? There were a number of participants who didn't want to do telephone interviews and said they wouldn't participate unless we had a web-based version. So we created web-based versions for these participants and also for participants who moved out of the area. We have quite a complex process to connect with a proxy as needed, who can answer questions for the participant. And we've considered various modifications to data collection. For the participants who come in for the assessments, we piloted a miniature data collection at home with them in follow-up 1. It really wasn't that successful because we realized that we needed 2 people to carry the equipment, and it just wasn't practical. And oftentimes the participant didn't have room in their apartment or their house in order to be able to do it. So we stopped doing that. But we're now thinking about other measures as we enter our last decade of data collection. We're considering more remote measures in people's homes. And we're also thinking about having mobile measures we've considered and we're thinking about, and we're developing a possible proposal to have mobile vans to be able to not necessarily go to a participant's home, but to go to a more central location so they don't have to come downtown, which, as you all know, is not great in this day and age. So I did want to talk about linkages. I'm going to start over here. So we have already linked our data in the CLSA with CANU, the Canadian Urban Environmental Health Research Consortium. So that's been for already 3 or 4 waves. So researchers have access to those data by going both to CANU and to CLSA. You can get linkage through the postal codes, so you can get those linked data. What I'm really excited to report, because I think this is the first time I've ever spoken about successful data linkage with health administrative databases. It's now possible in 3 provinces. The CLSA data have now been shared and linked in 3 provinces. We're at the agreement stage in 4 provinces, and we're in discussion in 3 provinces. And I have to give a shout out. I know he's not here, but I have to give a shout out to Andrew Costa, who actually was a driving force to get this going. How did we get this going? Well, we got this going through the Health Data Research Network. And the goal of our collaboration is to facilitate the linkage between the data sets and the HDRN data centers. So that's possible now in 3 provinces. The data are actually there. And there's also a strategy to kind of develop resources that are consistent across provincial and territorial data centers so that it isn't different in different locations. And there's an activity to look at various scientific opportunities to demonstrate the impact of the data linkage. This is all relatively new, but I think very exciting. So I'll just give you the status here. So the blue provinces are the provinces where the data has already been received and linkage has been done. So in BC, there was a successful linkage of 99.7% of the participants. In Ontario, 99.9%, and in New Brunswick, 98.6%. At Quebec, you're asking, I'm sure people are wondering, we're having really great conversations with ISQ, Institut Statistique de Quebec. We're at the stage of reviewing memoranda of understanding, working out some of the details. So I really think that that's going to happen fairly soon. My staff at the Data Curation Center have some very successful experience in creating these data sets and sending them to provinces for linkage. So I think once we get the okay in Quebec and in the other provinces, I think this will go pretty quickly. And for those of you who use linked data, this is a very exciting aspect of the CLSA. Okay, so how do you get these data? So I said it's a platform. So the data, the alphanumeric data, are available to researchers and trainees in academic settings and research institutes in Canada and around the world. So we have researchers around the world, but of course, primarily in Canada. The access fee, I believe, is relatively small, and we provide a fee waiver for graduate students if the project is for their thesis alone, and also for postdoctoral projects or projects of clinical fellows. So we give a fee waiver, so there is no cost for the core data. We've introduced governance over the use of our Indigenous identifiers. For a period of time, we suppressed the Indigenous identifiers until we were able to put in place governance. So now individuals who wish to use the Indigenous identifiers in the CLSA, you can add that to your data access application and it will be reviewed, and there's possibility that you could get those data. We have 4 deadlines every year, so 2 of them are passed already for applications. So the next one's July 10th, and there's another one in October 2nd. We have an access email for any questions that people might have, and we have a web-based application system where you go in, set yourself up with an account, and you submit your application online, and you will receive all of your communications back online. And when you get to the point of getting access to the data, you will be able to download it from the online application as well. We try hard, although it's very difficult to keep up, to have as much in the way of data resources as possible. So we do have a website which is actually in the process of being updated, but still exists in its current form, www.clsa/elcv.ca. And we create data support documentation. So we have all of the questionnaires are listed there. We have protocols there. We have data dictionaries. We have several documents describing the sampling weights and how we got there. We have a document on the genomics data, which I didn't even mention. People have access to the genomics data. We have information on how derived variables are created. And we have a lot of other data support materials. And then we have descriptions. For instance, you'll see here descriptions of the COVID studies. We also have a list of all the approved projects, which I think is very helpful to look at if you're thinking of applying. So what are the fees? We call it a partial cost recovery model. So for the alphanumeric data in Canada, researchers are asked to pay a data access fee of $3,000. I just signed off on an invoice because even as a PI, I have to pay for the data. I just signed off on my $3,000 in order to get the data for a project that I'm working on. For the US, it's $5,000. For the US and outside Canada, individuals are being asked to pay $5,000. And as I said here, graduate students receive a fee waiver and don't have to pay. So in order to be eligible for a fee waiver, you have to be enrolled at a Canadian institution, or if you're studying outside Canada, you have to be funded by a Canadian funding agency. It is possible to get access to images and more complex data from the CLSA, And there are additional fees that are added to the regular $3,000 fee for image files, raw data, and data sets that require complex customization. And this is really to try and offset the time that it takes our staff at the Data Curation Center to pull this together. So this is just an example of the types of images that you could get. So you can get the raw data for the cognition, you can get the retinal scans, you can get the images from the DEXA and the Cine loops, etc. So you can get that, and there is an additional fee, which is good as of, well, that was presented on October 30th, 2023, so it's still appropriate. So how successful in terms of the value proposition has the CLSA been? Well, we've had more than 600 research teams have come to the CLSA to access the data. And I have to say the application process has a very low rejection rate. Basically, an application is going to be rejected if there just is not enough information to be able to assess what the researcher wants to do, or if they're asking for data that the CLSA doesn't have. And that does sometimes happen. And that's why we really try to keep our data support documents up to date so researchers will know what is available. So I pulled this. This is not completely up to date, but it shouldn't surprise you to see that most of the applications coming from Hamilton, which is where the lead PI is, and a lot of the researchers on the CLSA are. But Montreal is next. So we have 89 applications on the go from Montreal, and that includes all of Montreal, etc. And we have several international from other countries outside Canada. And one thing I didn't put it anywhere here in my slides, but I wanted to mention when we talk about the data access fees, CIHR has worked with us over the years to actually launch, if people are not aware, a CLSA Catalyst Grant. So this is a grant, it's a one-year grant. Historically, it's been $70,000 for 1 year. And this is a grant to analyze the CLSA data. So I would really advise you to keep your eyes open to look for these grants, because it's a great way to be able to access the CLSA data and get funding to do so, funding for students or funding for a postdoc or funding for research assistants. I just recently received one. I'm very excited to get it, but I'm paying my $3,000 out of that grant. So I didn't want to forget that. That's been an initiative of the CIHR. We just had one last fall, and it's highly likely that there will be another one this coming fall. So keep your eyes open for that. So this is just the few people. This is one of, we meet once a year face to face. So this is just a group of some of the researchers. We were meeting in Burlington, Ontario to discuss follow-up for us. I wanted to just show you that. And I've listed here some of the members of the research team. We have a large group of people who are leads of working groups who help us at each follow-up wave to review everything that we have been collecting to determine what should stay, what should go, and what new we should be asking about. So I have to acknowledge, I mean, we've been funded from 2001 by CIHR and CFI. We've also been funded through the COVID Immunity Task Force, which I mentioned, the Weston Family Foundation, Juravinsky Research Institute, Public Health Agency of Canada. And I have to say, one of the things I'd really like to say is to the participants, they have stayed with us incredibly, and they do a lot for us. They come to our sites, they spend 3 hours with us after having a 1 hour interview, or they spend an hour and a half to 2 hours on the phone. And in COVID, they were contacting us and saying, when are you going to come back and interview me? So I think we wouldn't have a study without these folks. And also a shout out to their families and friends, particularly those that pick them up and drive them, in our case, to Guy Street, and drop them there and then come back and get them. I just think that this is why our study, I think, in terms of its retention, has been so good. So I just want to finish. There are two very special ladies in my life. On the right-hand side is my mother-in-law, who passed away at the age of 103. She actually was a person that I took the questionnaires to when we were first starting out and asked her to test them on so that we could get some piloting on someone she was already in 90 at the time when we were developing the questionnaire. So shout out to her. And on the left is my mother, who passed away a couple of years ago, who was actually chosen at random as a CLSA participant. So she was the person who would give me feedback on the questions, some of which was not always positive. But so at that point, I think I'm going to stop and ask if people have any questions.
Fantastic. Wow. Congratulations. This is really, really impressive work. What an endeavor. Really fantastic. So happy to see that you've been able to to make this happen. Very, very impressive work. Sasha, you have a question. Do you want to unmute yourself?
I do. Congratulations, Christina. I remember when this was first getting started, and I think it was something like 20 years ago, and you have no more gray hair than you had then. So congratulations on that front too. So how the heck will you deal with the way that administrative data are released to investigators? Because I have been dealing with linking. I had patient consent to link with Quebec administrative data, and they're telling me that even though I have consent, they will not release data to me. Yeah, even with consent. So it'd be interesting to see what happens with you. Maybe this will be a test case, but in the past, with patient consent, it was not a problem to get information.
Yeah, I know. I mean, I did linkage for a previous study of dementia that I did years ago, and you got it on a disc and all that kind of stuff. So we're working with ISQ, and so far I have to say the level of enthusiasm on those calls is palpable. So I think that, partly I think that they see that they could use the linked data themselves to do certain projects, and we're still at the stage of negotiating the details, but we are really there at the level of negotiating the details. So I won't be able to answer that question.
Right.
And I'm for the first time, I always thought, I know we're being recorded. I always thought Quebec was going to end up not having linkage. We even went to a discussion about whether we needed to add a more detailed module asking questions about healthcare utilization on a more regular basis, because I was pretty convinced it wouldn't happen. I'm now convinced that it will.
Right. So getting the linkage done is one thing. I think that's not going to be a problem. Yeah. The question is, we were really surprised when having with patient consent, we were able to get linked administrative data in the past. Now we're being told that our multi-center study, which includes linkage to administrative data in Quebec, we have to put all of our data on CADRS, which is not feasible. So it'd be very interesting to see as you have these conversations. Perhaps, Christina, it will help other people work through this untenable situation. So
I hope so. I mean, I think I was honestly surprised at how enthusiastic the group were. And I think maybe the fact that we're working with the Health Data Research Network and we're already quite far advanced in our discussions with them sort of made things positive. But we don't have it yet. They haven't received any data. We put our foot down initially when we used the CCHS, where Statistics Canada said you're going to have to put those data in a research data center, and we said not doing it. We're not. Right. People have to have access to the data, so we'll see.
Right. So, good. Thank you.
Thank you very much for that. Charles Canet, you have a question?
Thanks for a very challenging, huge project. When you started the project, watch monitoring devices weren't yet invented, I believe.
Right.
Any thoughts of incorporating whoever has those devices? Like, we have continuous heart rate monitoring, saturations.
Okay. That's what you mean. Okay. You mean for the more clinical purposes.
Yeah.
I think we'd have to really think about that, because I sort of alluded to the fact that it's been challenging with the wearables of any kind. We have an relatively old participant group now, And we actually had some older interviewers, and the interviewers were having trouble explaining the wearables. So I think we'll think about it, and because I think when we move to a place where our participants are very unlikely to be able to come in, I think we're going to have to do something remote. And maybe that will be what we use. So we haven't had very detailed, we've had a few presentations from different companies that do different things, but we put that on the back burner a little bit at this point.
Thank you. Sasha, you want to unmute again?
Yeah, I can answer this. Yes, I assume we hope it's going to include the drug data. And if I'm not mistaken, we reconsented all our participants fairly early on to go 10 years before baseline.
So that could be interesting also, because I have found that they only want to give you drug data for the specific drugs that are of interest, but perhaps again, you'll be forging some new paths for us.
Yeah, hopefully, fingers crossed, probably in our lifetime. Ariane has her hand up.
Go ahead, Ariane.
Thank you so much, Christina. What a tour de force. It's really fantastic to see examples of this kind of leadership in data acquisition. I'm wondering, are you linking with other disease-specific cohorts, like, for example, even CCNA on neurocognition, or other disease cohorts that might be, let's say, cardiovascular, or because there's a wealth of information there, and I'm just trying to think of how we could sort of help catalyze the use of data like this, which is so rich.
So, early on, we tried to connect with everyone because harmonization was very important. We didn't want to be the one study that used different measures than everybody else. So we did that early on. We obviously know CCNA, for instance, very well, and we sent them, when they started, all of our questionnaires and all of our measures. So we try to harmonize. Linking, obviously we can't link because we don't have the same participants, and I think if Isabelle Fortier is here, we have all that stuff is on the Maelstrom website for the harmonization. We have talked about a new initiative where we sort of want to highlight other cohorts on our website that we consider sort of sister cohorts. There's some learnings. There's a centenarian cohort, I think, in BC that we're very interested in. So we're trying to do that. We have our international advisory committee has people who lead major cohorts. So linking, yes, in that sense.
Thank you. David, do you have a question? Do you want to unmute?
You have great data. Well, there are actually two things. Are you linked into things like Cartesian in Quebec, which collects, again, large numbers on populations? And the other thing is, when you started, everything was SNP-based, but now you need a very small amount of DNA to do whole genome. I just wonder if the material is there and whether it could be used in the future for whole genome analysis.
Well, the second part of your question is out of my area of expertise. I mean, we've got Brent Richards is actually the person who's working on these data for us, and we have the samples. I mean, we don't use up all the samples, so there are additional samples. And again, linking with Cartesian was, I think, in the field before we were. So linking means having an open form of communication, I think. There are some comparisons between our participants and the Cartesian participants. So yeah, I mean, I think maybe Ariane was touching on something that I think many of us feel is missing in Canada. There isn't an overall cohort initiative in Canada that brings together all of the cohorts, so that when someone wants to start a cohort, they can build upon the lessons learned and even the infrastructure, because we have a lot of infrastructure, the infrastructure of others. And I think that's really missing in Canada. And, surprising, not everybody knows about the CLSA, so they don't know that if they want to do a study and they want to use DEXA, we've got a DEXA machine sitting at Guy Street for research that someone can use. So I think that we're missing a whole initiative, and I think the questions about linking are relating to that.
That could be part of your legacy project.
I hope so. I hope so, because what happens with those other cohorts when they're finished? Where does their infrastructure go? Who's going to look after our samples? Eventually the researchers are going to retire as well. So that's a big challenge.
Christina, have your patients, have your participants in their consent form, does it say anything about commercial partners that might be interested in the data, and have they signed off on that?
Yeah. So we basically, the way we actually work at our consent sort of says that they can't have access to the data, but if there are commercial groups that connect with a researcher, then because we need ethics approval, so we can't give data or samples. Well, we have given samples because some of them have done in-kind analyses for us, but if a commercial organization connects with a researcher and comes to us, and the researcher is the lead, then that we can provide data to them, data to the researcher, but not to private companies at this point. But we're rediscussing all these things because a few people have alluded to already. We developed everything in relation to consent and what was possible in 2008, 2009, and the world has changed dramatically since then. So we are going back and looking at our consent forms and how can they be interpreted and what is it that we can do. So that's something we have to look at, and that's something that I never anticipated in a longitudinal study. Perhaps I should have. That it's not only the science that changes over time, it's the policies. The whole management of Indigenous identifiers has actually changed since we began. And so we used to release the Indigenous identifiers, and then we stopped because we realized that we understood now that we needed to have Indigenous governance over those data. And now we have that. So we're releasing them again. So
fantastic. There's a question about biospecimens.
Yes, they're stored. They're all stored in our biobank.
Can they be accessed?
Only if you're prepared to analyze about 28,000 of them.
Okay. Sounds good.
Fantastic. Fantastic. Are there any other questions for Dr. Wolfson?
Christina had said something about First Nations governance. I think, could you share something on that, please?
So we have an Indigenous researcher who's actually developed a governance strategy. And when people apply for the data, they have to tick a box to say that they want the Indigenous identifiers, which we have. And they also have to say how they plan to use this information and how they have connected with Indigenous communities. And then that's reviewed by the Indigenous researcher. Because we have, we ask people about language, we ask them about their cultural background, and created, based on that, an Indigenous identifier. And we're actually considering modifying the way the question is asked in the next round of data collection to be a little clearer, that fits in with the way the Indigenous communities see these characterizations. And we're also probably going to add something about being two-spirited. So, we've really worked very, very hard with the Indigenous community to make our study, which was never meant to be a study of Indigenous populations, at least accessible and useful in a limited way. We don't have anyone who lived on a reserve at the time that we recruited them. So these are people who were off their First Nation reserves, but still there could be some useful information there.
Fantastic. Well, thank you so much. Really, congratulations once again, because this is really outstanding work. And I think, it's the type of presentation we'd like to see where you're at in a year. So hopefully we'll have you back here next year and you can tell us some of the new developments. If people want to reach you, I guess, with respect to this, do they go right to you or to CLSA? Who would be the contact person here at McGill?
It's fine to contact me, initially, and I can then figure out where to send people. I'm happy to do that, because to try and navigate, is it this email address or that email address? Send your emails to me if you've got questions. And I really want to ask people to really seriously take a look to see whether these data could be helpful for you or for a student, maybe for some pilot information. I think there's a lot there that hasn't been looked at so far.
Thank you so much.
Okay, thank you.
Terrific. Congratulations. And thank you, everyone, for your joining us and for your participation this afternoon. I wish everyone a great day. Bye-bye. Thanks.
Thanks. Bye-bye.